Thank you very much for the invitation. It's a pleasure to come back after. I do come back very often. Some people have been complaining, but I've been in England for 36 years, and they complain because now I've been back about twice a year, and it's too much. Anyway, I thought I would share with you this real worrying topic, because we are having a lot of financial problems. As you know, the UK is not doing so well. And I don't know if you can see, this is the jolly NHS manager in the National Health. There is no longer enough money to do cataracts, and when they're talking to the manager there, he says, just get them to wear sunglasses. I do that all the time. And we have managers who are paid twice the salary of the senior consultant, and they work from home. So we have problems on the system, and at the same time, you don't know if anyone has watched the news, because last month we had this case of an optometrist, an optician, who saw a child and missed the fact that the child had swollen discs, and she was taken to court, and she got 2 years prison sentence, which is a very scary thing for everybody. I think in the last month, every week, I've had at least 3 children sent by opticians saying, query swollen discs. Well, slightly irregular margin, optic nerve drusen, why take a chance? You go to prison if you miss it. It is a scary thing, because we all make mistakes. And if when we make a mistake we'll go to prison, we will all end up meeting in prison. But I think when you get terribly bored with what I'm telling you after this, just try and keep remembering that although it might be too finicky to try and sort of look at everybody, just think, if I miss this one, I might end up in prison. And I will start by making sure, something I did, sorry, making sure that we're talking about the same thing, and we're talking about screening as opposed to monitoring. So is that screening is about trying to find out if a condition exists as opposed to monitoring a condition that has been diagnosed. So it's a condition that has not been diagnosed yet. Obviously that child has a condition, but the eye may or may not be involved. So hello? Yeah. Obviously, there is no point in looking for a condition if we have no treatment for it. So if there is no treatment available, there is no point in screening. It's a waste of resources. But if a condition is treatable, we then have to think about whether it has signs or symptoms. If it has no signs detectable by the parents, and when it comes to symptoms, we have to think if the child obviously is too young to mention the symptoms, or if he has some other difficulties, like children with learning difficulties, etc., who might not explain their symptoms. So it's not just the age. So we'll go through some categories. The first one, the obvious one, is premature babies, and you probably, I'm sure you don't need people to start wasting your time on the importance of screening for ROP, but I will then go through the other categories, which are the children with learning difficulties, those with eye diseases, those with systemic diseases, and those who are on some medications. So as far as the ROP screening, it is pretty obvious why we screen them. But it is not just the ROP, and that's why I'm putting down here the fact that we will obviously follow the guidelines for screening for retinopathy as such. But then the question arises whether we should continue to look at those children to screen them for other conditions. We know that those children are at risk of high refractive errors, high degrees of myopia, strabismus, glaucoma, cataracts. They can all happen. Now, I know of colleagues who have even after treating ROP, said, I saw the baby, the ROP had regressed, so I discharged, and 2 years later it turns out the baby has some other problem. He's deeply amblyopic in one eye, he's very anisometropic, etc. And I think that every child who has reached stage 2+ or stage 3, whether they reach the threshold level and were treated for ROP or not, need to be monitored, because it's a combination of factors. They are at risk of those other conditions, and it has to be said that many of them also have the cortical problems that may be a second reason why they should be monitored, because they will not express their symptoms, or they may have other problems which the parents assume that it's all due to the fact that they have some neurological problems, but they are further handicapped by an eye problem that has been missed. I'm sure we could go to prison for that. So we're going to screen for the ROP itself following the local guidelines, but we'll follow the others up to the age of 2 or 3 years, or a bit longer if they have some kind of neurological or developmental abnormalities. Children with developmental delay as such are a very difficult category, and that includes either cerebral palsy, various syndromes, being Down syndromes or others, and those with just learning difficulties like autistic children. Now, they may just have the neurological problem, but their neurological problem may be exacerbated by the fact that they have some eye problems. They may have refractive errors. They could have ocular features of a syndrome that have been missed. So again, we don't know about their eye problems until we screen them. And these eye problems, particularly the refractive errors, may have a considerable impact on them, and if found too late, will not be treatable. So I think there is a strong case for what the practice we do, which is to continue to see those children at least once a year, to do visual acuities and refraction if the acuity isn't as expected and equally good in both eyes. The next group are children with eye conditions, and you may think here there is a bit of overlap between are we screening or monitoring. Well, I think we're screening in the sense that a child with just slightly progressive myopia or progressive astigmatism may not yet have the label on their head that this is keratoconus. So in a sense, until keratoconus has been confirmed as a diagnosis, they are being screened. They are not being monitored. But whether you screen them or monitor them, I think it's now very important to do so because of the fact that there is a treatment. And the other eye condition I'm thinking about, which is, if you want, in the region of the eye, is nevus of Otter. Well, the keratoconic ones often turn up with increasing astigmatism, and I have realized that over the years I've made the mistake of sending people away when the parents said, oh, the myopia is increasing, but sometimes before they have marked astigmatism they start with myopia, and then they become more astigmatic, and then it increases. So I think children with myopia should be followed up for a while and see if it is progressive, and so is if the astigmatism is progressive. And we know that in particular those with atopia are more at risk of rapidly progressive disease. So if you're going to consider cross-linking, it is important not to wait for too long. Initially we would see them every 3 months, and then if stable every 6 months, do the refraction, and if you're starting to suspect keratoconus, obviously you're going to do the pentacam to monitor them. The nevus of Otter, as you know, have the pigmentation around the eye, often pigmentation of the sclera, and they are at higher risk of malignant melanoma, and they are at higher risk of glaucoma. So again, it is one of those conditions that you could easily dismiss and say, well, very little is being done, although, as you know, our dermatology colleagues have treated quite a bit of the cosmetically poor cosmetic appearance because of the pigmentation with laser and other techniques. So I think, again, because of the risk of glaucoma, they should be monitored, I should say screened yearly, and have a fundus examination because of the risk of malignancy. Now, some of the systemic conditions I have in mind are infections, and babies born with toxoplasma can develop secondary lesions, and they can go on for developing secondary lesions later on in life, but it's not unusual to see them in the second decade of life. Then there is the phacomatosis, juvenile idiopathic arthropathy, sensory neural hearing loss, and diabetes. I'll go through one by one. Now, the infections are mainly toxo and CMV, and we know that babies with toxo and with CMV can go on progressing. And indeed, babies with CMV, the decision regarding whether to treat or not is often based on whether they have ocular manifestations. So these would not necessarily be there at the first examination and may appear later on. And so could the toxoplasma ones. So I think we are duty-bound to screen them. And obviously, if we found a condition, we have to monitor it. The phacomatoses are a large group of conditions, and I know some of the syndromes become terribly boring because the names are very complex. But the main 8, if you want, there are 4 better known: the neurofibromatosis, tuberous sclerosis, angiomatosis of the retina, which is von Hippel-Lindau, and Sturge-Weber. And there are 4 which are sometimes considered phacomatoses. Not all the textbooks agree, but I'll go through the 8, mainly the first 4. Now, with neurofibromatosis, leash nodules is not something we screen for. You look for it initially to make the diagnosis. But once you have established the fact that the child has neurofibromatosis, then we're screening for other manifestations that may not have been there at the first check, mainly gliomas. So they are regularly seen for the risks to check their optic discs, check their vision, and if they're a bit older, you may be able to check their visual fields. In neurofibromatosis 2, NF2, they have a significant risk of cataract. Many of them develop lens opacities. So again, if you see them and they don't have the lens opacity to start with, I think they should be screened for that, as well as, of course, the retinal lesions. So for NF, generally, we see them once a year, do the acuity, the color vision, check the pupillary reactions, intraocular pressures, and then do the fundus examination. When they're a bit older, you do the visual fields. Tuberous sclerosis, the hamartoma itself is not a nasty lesion. It can progress, but it's not a malignant lesion. However, many of the children with tuberous sclerosis have very difficult to control seizures. So they end up being on vigabatrin, and the vigabatrin is the one which has significant risk of ocular problems. So we tend to see them more because of the medication rather than the condition itself. So again, we check their vision, check their, the ocular lesion to see if it's progressing, but this is monitoring. But we need to screen them because of the effect of the vigabatrin, which I'll come to later in the last group. Von Hippel-Lindau has the hemangioblastomas, which can be in the eye or in the cerebellum, and up to 85% of them with the mutation have the retinal lesions. So we really have to watch for it, and these can be multiple. They can be in one or both eyes. And although the lesion is not easy treated, if there is exudation or leakage, then they are treated with laser. So again, annual check up to maybe from the age of 5 is when the lesions may start progressing and leaking. There is a site with recommendation on how and when to follow them up. This Sturge-Weber syndrome have the calcium deposits in the brain, so you're going to scan them to start with. Remember, although the skin lesions are often along the distribution of the trigeminal, it's not always the case, but again, they have a high risk of glaucoma, so you want to monitor their intraocular pressures regularly. I used monitor again, I meant screen, because until you find that they have the pressure. So having the pressure fine for a while doesn't mean that we can stop seeing them. And the ataxia telangiectasia, they usually present more with eye movement problems. They have problems with initiating saccades or with strabismus. And this, as such, doesn't have to be monitored. They have the telangiectatic lesions on the conjunctiva, but as we don't do anything about it, again, whether you see them yearly is questionable because there isn't really much we can do for them. We tend to monitor the squint, but screening is not necessary if there is no eye problem at the start. The incontinentia pigmenti is one that has caused a lot of problems because people have seen them once, send them away, and as you know, they get the skin lesions, but they also get proliferative vasculopathy, which is very similar to sickle, avascular areas, new vessels, and then they're treated, I said sickle, like ROP, avascular retina, new vessels, hemorrhage, retinal detachments, etc. They behave like ROP, so they need to be watched and treated with laser. When and how to screen is until the age of 2. The last 2 hardly need checking. So I will skip this one, and in summary, most of the the phakomatosis need treatment except for the last 2 there. The JIA are screened because of the risk of uveitis, which I'm sure you all do. We have guidelines saying every 3 months. I cheat and do that every 6 months when they're fine. Children with hearing difficulty, we have a protocol saying they should all be seen. And I think if you're going to screen them, there is no point in looking at the retina because the pigmentary lesion will only appear by the age of 10 or 12. But if you start saying there is genetic treatment, you should do regular ERGs. Finally, diabetes is obvious, like for adult diabetics. And the last group is the children on medication. And as I mentioned earlier, vigabatrin has a high risk of problems. Regulated interferon, which is used a lot now for hepatitis C, have a considerable risk of visual problems. So all of them have to be screened on a regular basis. And ethambutol, there is a lot of written, but it's very rare to have eye complication in children, so you probably can afford not to screen them. And regular transfusion, they get toxicity from iron. So in summary, all those with infection, CMV or toxo, phakomatosis, JIA, sensory neural problems, and the diabetics, as well as those on medication, the 3 medications I mentioned need for. Thank you very much.